Hello everyone, welcome, good evening and welcome back to the CRISP TV. We are having outstanding sessions right now at the CRISP conference, both in the IC hall as well as the 360-degree hall. And I'm your host. My name is Dr. Abad Khan. I'm an interventional cardiologist practicing at St. Joseph Hospital, Ghaziabad. Today, now on the second day in the evening hours, we have another exciting guest with me and an international faculty, Dr. Ayush Khurana. He's a consultant interventional and structural cardiologist at Morriston Hospital, Swansea Swansea, UK. Sir, welcome to the CRISP TV, sir.
Yeah. Thank you.
Thank you.
Thanks for the
Uh,
invitation. Yeah.
yeah. So, Dr. Ayush, sir, you have been trained in UK and currently also practicing in UK. How have your experience been seeing the growth and the expertise available currently in India? Strictly speaking, in the terms of treatment planning and execution for the patients of TAVI.
Yeah. So very interesting question. I think you've asked me to compare what I know about practice in India to the
Yeah.
UK. I think there's no doubt that um, that the physicians and the capability that the physicians, the cardiologists have in India is par excellence. The challenge has been obviously bringing transcatheter therapies to the population that India has and serving its needs. And combining the skills and the knowledge of the cardiologist with indigenous sort of development of transcatheter therapies, stents, valves, etc. I think this is now being applied to a very high standard. Uh, the availability of certain indigenous therapies, also set patients up for lifetime management options as well, and all of this is really exciting to see from the outside.
Oh, so Dr. Ayush is extremely happy and extremely convinced that the work going on and the level of care going on in India is actually catching up to the world, the Western world right now. Sir, you already have a wonderful session on TAVR, and you will have actually. And now we, as a cardiologist in India, following the recommendation for the calcific tricuspid valve stenosis, and the management is almost universally the same almost everywhere. What do you think lies for us in for the aortic valve disease management for the bicuspid aortic stenosis as well as for the pure non-calcific aortic regurgitation? Will that be covered with transcatheter system too very soon?
I think we are certainly heading in that direction. The population in India and the percentage of bicuspid valve pathology, aortic valve pathology that you see here is much higher than the West. However, again, sort of indigenous technological development has meant that there are many more options available now. So that enables the cardiologists, the sort of TAVI implanters over here, to actually choose the right valve, the right size valve for the right patient. In terms of bicuspid aortic stenosis, that is a very important thing because these patients are at a higher risk of valve-related complications at the time of the procedure. So rather than trying to get a certain size valve that's available in the market to try and fit in, into that patient's aortic valve anatomy, it should be the other way around. And I think India is well on its way for that. Pure aortic regurgitation, I think I have my session later on this evening on that, so I'm excited about that. I think the journey has reached an exciting stage. Pure aortic regurgitation, occurs in about 10 to 12% of patients as people live longer. Open surgical option, which used to be the only option available, doesn't really apply, and the surgical risk is higher. So there are some new dedicated devices that are coming through. There's new evidence coming through. So we are about to enter, I think, a very exciting phase for transcatheter management of aortic regurgitation as well.
So a lot of patients, and he is advising that let's be patient, and the future seems bright for the TAVI implanters for the aortic regurgitation as well. So now with the Resilia tissue technology and the Edwards coming in, and hoping other manufacturers also will be bringing their new generation of devices and these anti-calcific agents for them. We are now aiming for more than 70 years has been fine. Now we are aiming for even younger populations, and we look at a lifetime management for these kind of patients, for younger patients. How do you see that this involves for long-term second and third valves, which we have to implant now with the more durability of the valves? It seems is coming up.
Yeah, so a very sort of in-depth question that. What I would suggest is, I think as cardiologists, the first decision about the type of valve and indeed the type of aortic valve replacement sets the patient up for lifetime management options. As we know, a surgeon explanting a TAVR valve in the lifetime management journey of the patient is very, very high risk. And therefore, the onus is upon us as cardiologists, interventional cardiologists, to make sure that the right valve goes in for the right anatomy, the first time around. And that, coupled with what we were previously discussing, bicuspid valves, means that we also have to be honest that some of these patients, when their bicuspid valves, sort of aortic stenosis, may not be suitable for TAVI as the first option for lifetime management. As we know that doing a TAVI in a surgical valve, in a bioprosthetic surgical valve, is quite easy. There is the question of durability of the prosthesis versus the characteristics in terms of allowing a TAVI and TAVI later down the line. So to summarize that all, I would say if the patient's younger, the Resilia technology holds promise. The short frame valve, balloon expandable valve, would be my valve of preference in terms of the first implant if I'm going to perform a TAVI, and that opens, with good CT planning, the discussion even before I put the first valve in for options in terms of TAVI and TAVI and lifetime management for these patients.
Perfect. And as Dr. Ayush is saying, that planning is utmost important if you intend for this therapy for younger patients or patients who will have a second or third valves down the line in their lifetime. Planning and sort of discussion on the first valve remains utmost important. And
Absolutely. And if I may add, I think it is imperative that as we develop our experience in TAVI in India, that TAVI implanters get upskilled to reconstruct their own CTs. In lifetime management, assessing the coronary heights, just visualizing whether a TAVI and TAVI would be possible in the future, even before the first implant, through dedicated CT reconstruction, is critical.
yeah, absolutely, absolutely. Planning yourself, not relying on the data from the CT available, but planning the cases yourself for the first implants for the lifetime management remains absolutely critical, and that is what Dr. Ayush is saying. What do you still see that the Achilles heel is for TAVR for aortic valve interventions, so that we are able to convince that going lower or younger maybe an option in future, that going for younger patients. So what remains the Achilles heel? What is one thing that you are able to convince yourself that going younger may be an option in the future?
So I think the Achilles heel is heavily calcified bicuspid valve pathology. Its pros and cons. I think calcification is a friend for TAVI. We won't be able to, TAVI wouldn't have followed the journey that it has if it wasn't for how the aortic valve complex is, and in terms of how calcific aortic stenosis allows for very predictable TAVI implants. But at the same time, in bicuspid valves, particularly with calcified raphes, that is a weakness for TAVI because that does increase the risk of annular rupture. So, how do we get over that? I think there are 2 points. One is apply the right technology, as I said earlier on,
Yeah.
if it's feasible and if it doesn't increase the procedural risk. And 2 is honesty with ourselves. Honesty in terms of there will be a certain subsection of patients as we go younger, because as you go younger into the 60s, the predominant mode of stenosis is bicuspid stenosis. So the percentage of bicuspids get higher. And there will be a subsection of them where we'll just have to put our hands up and say, this patient's going to likely come back to me in 8 or 10 years' time or 12 years' time, even if he has a surgical valve. So let's be honest about this and let's just do the right thing the first time around.
Perfect. Absolutely. This is what we have been trying to teach, and this is what Dr. Ayush also is trying to preach, that be honest and meticulously plan the first time around the valve which you are going to place, and then let's hope for the best and hope for the future that the technology comes up, which is improvising on the already available technology and the gadgets we have. Sir, if a young interventional cardiologist from India, he's trying to pursue structural interventions, is doing fellowship from abroad, from outside of India, a mandatory thing before starting doing intervention, since these kind of fellowships are not available in India?
No, that's a very pertinent question looking into the future. So I would say as we've all experienced, interventional cardiology is about the willingness to learn and apply that learning, and then learning by volume, so exposure to volumes of procedures. If you would have asked me this question a couple of years ago, I would have said it's absolutely mandatory, because what um, the UK, where I am, perhaps offers is we have a relatively, limited number of centers, but very high volumes of TAVI and other structural interventions being performed in those centers. So that allows for fellows to learn through very high volumes in a short span of time. A typical fellowship is about 1 year. As the volume of structural interventions grows in India, I do think, and that is probably what's starting to happen now, there will be opportunities for fellowships over here for the future interventional cardiologists to get upskilled in a span of a year or two. Uh, and, uh, and therefore it will not be mandatory per se. But in the UK, I always welcome, dedicated, interested Indian interventional cardiologists to come down and, and get the learning and exposure while the volumes still go up in India.
Or to all the interventional cardiologists aspiring to be structural interventionists, Dr. Ayush has directly invited you that please apply to him and have a word whether he has a space to apply for a fellowship there. So, how have you been liking the CRISP conference? It's the first day today, and how do you like this concept of having and attending this conference right now?
I think it's absolutely fantastic. Congratulations to the organizers, the organizing committee, and everyone. This concept is very, very exciting. The setup, is excellent for learning in a short span of time, and it's a very, very comprehensive program that you have laid out as well. So, it is excellent, very enthusiastic, very keen to contribute, and thank you for the invitation as well.
Thank you. And he was Dr. Ayush from lending us some wisdom and advice for the future. Thank you so much, and see you with the next guest on the next podcast.